Good afternoon, everyone. It's a pleasure to present our session today, which will be about corneal infection instruction course, which we're going to cover all aspects of infective keratitis. It's a pleasure to have distinguished speaker from different area. All of them, they are consultant corneal specialists. And first talk will be by Professor Mohammed Hosni from Egypt. Basically, we'll talk about back cross-linking, which is the new modality for treatment of infective keratitis. I'm really looking forward for this talk because this is a hot topic as far as we're concerned. It's a pleasure to have Professor Mohammed with us. You can share your screen.
Okay, so everyone, Assalamu alaikum wa rahmatullahi wa barakatuh. Again, it is an honor and a pleasure to be here with you. Among very close friends, close to my heart, Dr. Usama Al-Gledi, Dr. Murad Buthani, Sandeep Mitra, and all the gang. Thank you so much for inviting me to be here. I will try, Dr. Sharif Amira, my good old friend. I will try as quick as possible to give a brief talk about the PAC-CXL or the photoactivated chromophore for keratitis, corneal cross-linking. Now, the rationale behind doing cross-linking for patients that do have an infection in the cornea is that it is a potential alternative as a primary or an adjuvant treatment to topical antibiotics. Now, nowadays, there's a big problem that is not being solved by the day, which is the development and the increase of antimicrobial resistance. This is becoming so prevalent, especially in our parts of the world. And in spite of basifloxacin being the only antimicrobial that we can actually say that doesn't have any resistance at all up to this very moment, some organisms are not actually sensitive to basifloxacin. So we do have all the armamentarium of antibiotics that are becoming less and less effective. It may limit the need for hot keratoplasty, and when I say so, I'm saying this with a grain of salt because I am a die-hard fan of keratoplasty assure or hot keratoplasty. I've done a lot of cases we have published, and we reported good results in spite of other reports in the literature that reported suboptimal results after keratoplasty assure. This was our publication in Cornea about femtosecond laser penetrating keratoplasty for treating infective keratitis, and we reported good results. In spite of this, I don't think this is the right or the optimal way to go. I think stopping the infection early on is much more valuable than doing a surgery to remove the infection. So how does PAC-CXL, how does cross-linking work in these subcategory of patients where you have infection? Firstly, the planar structure of the riboflavin inserts itself between the bases of the DNA and the RNA inside the organism, inside the bacteria. So it actually works inside the nucleus of the bacteria, and it causes lesions in the chromosome strands and then limits microbial mitosis and meiosis and replication. So this is how the infection itself or the organism itself is prevented from replication and from growth. Secondly, the release of the oxygen outside of the nucleus damages the pathogen cell wall, and this is very relevant in bacterial infection. Lastly, the activated chromophore, we all know this, cross-links the corneal stroma via covalent bonds, rendering them more resistant to enzymatic degradation. So the cornea becomes less and less susceptible to corneal stromal melting. And we all know some infections like Pseudomonas. We are the kings of Pseudomonas in Egypt, and we have a lot of Pseudomonas infection. And in a couple of days, the cornea can actually melt from the start of the infection. It's a very virulent organism, and it is pro-collagenases a lot, and it ends up with perforation of the anterior chamber. So how do you do a corneal cross-linking for a patient that has infection? Most studies use the good old Dresden's protocol, which is the 30-minute protocol originally described by Theo Zeiler. You have modifications, of course, the accelerated protocols, 9 milliwatts for 10 minutes, 18 milliwatts for 5 minutes, and 30 milliwatts for 3 minutes. I definitely do not recommend anything faster than the 10-minute protocol. Transepithelial approach has been used, but was not used to be efficacious in this subcategory of patients, but increasing the total energy from the good old conventional 5.4 joules to 7.2 joules had been used by two groups, the Swiss PAC CXL study, which I was a part of, and the CXL USA study. They are using actually 7.2 joules for patients that have ectasia or keratoconus, and they are reporting no extra damage to the endothelium. A novel technique in Italy has been proposed, and it's actually very smart. You don't have to remove the rest of the epithelium if you have an infected corneal ulcer. You just pop in the riboflavin from the ulcer itself. It's called cross-linking window absorption, or CXLWA, for the treatment of keratitis, and you load the cornea from the ulcer itself and then start your ultraviolet radiation. And it's like a compromise between removing all the cornea and the transepithelial cross-linking. Now, this is the group, or this is the study that I was involved in. It is the PAC CXL study. It won the best paper of the session in the ESCRS last time. And then we conducted the Egyptian study, which had a different angle. Why am I saying a different angle? Because the Swiss PAC CXL study studied the difference between giving the patients antibiotics only or doing these patients cross-linking only. Of course, the type of organisms that were enrolled allowed this. And we, in Egypt, we actually recruited very early patients for the PAC CXL study because the criteria of the study was to use only CXL. But we did a follow-up study, actually. It was an Egyptian study in our university. It was collaboration between Cairo University and Zazi University, actually. And the aim was to evaluate the efficacy of PAC CXL as an adjuvant therapy. So yes, we're going to give the patients the antimicrobials. We're going to do the culture sensitivity. We're going to bombard the organism with everything that we have. But if we add to our armamentarium CXL, would that be give us any difference in the outcomes or not? 78 eyes were with clinically suspected infections were enrolled in the study. They were classified into two groups, and it was totally random. The group A received topical appropriate antimicrobials only. Group B had the same, but we had a single session of PAC CXL before we started the antibiotics. Now, the results were compelling, actually. There was a big difference, not a statistically significant difference, but a big clinical difference, which is, of course, statistically significant. Complete healing was observed in 77% of the patients that had antibiotics only, and this was, in my opinion, a very good clinical success. But in 97% of the patients that had a combination of CXL and antimicrobials. Again, the mean resolution period was 11 weeks in the patients that had antimicrobial therapy only, and 7 weeks in the patients that had an adjuvant cross-linking. Again, in resistance, we had 2.6% in our cases were resistant to the treatment of CXL and antimicrobials, while 23%, which is 10 times as much, had resistance in antimicrobial therapy alone. So this is a patient, this is an example, this is a patient that came to us. She had a cross infection between, a combined infection with Acanthamoeba and Staph aureus. She had a very nasty infection in the cornea. B-scan was normal. We did the culture sensitivity, and we knew that this patient had a Staph and Acanthamoeba, but she was negative for fungi. These were the microbiology. I'm skimming through the slides not to take too much time. And we did a single session of PAC CXL before we started the medical treatment, and the follow-up was good. I'm sorry for the quality of the photos, but again, you can all see 4 weeks later, she was good as new. Case of fusarium, and this was a fungal infection, again, improved. Candida, again, improved. So we had many improvement in the cases that we combined cross-linking with antimicrobial therapy. And this is the recent publication of the PAC CXL study that I was a part of. And it resulted in, it shows the results that PAC CXL alone can be very effective as antimicrobial therapy. There was no statistically significant difference between both groups. So in conclusion, I think PAC CXL is proving to be both effective as a monotherapy and as an adjunct therapy in extensive sort of infections that we see in our part of the world, especially in the university arena. I would definitely recommend a combination of both. Different protocols are proposed by different study groups. All have shown success in controlling corneal abscesses. Standardization of the technique is yet to come, but it's just around the corner in my opinion, and in the looming danger of increased antibiotic resistance and the absence of new antimicrobial molecules, it may be our only hope. Thank you so much, and sorry to take a little bit more time.
No, thank you very much. That's great. One question, what's your protocol now? Which, if you want to choose the energy, what's your setting you recommend at this stage of time?
Now, I'm a conservative guy, Dr. Osama, so I do not recommend you going all with the full Monty. What I do is I do the accelerated. Sorry, I'm stopping sharing. Yes, okay. I'm doing the accelerated 10-minute 9 milliwatt protocol first before starting the antimicrobial therapy, and then I carry on with the normal antimicrobial treatment, and I'm having really good results, even in fungal infections, which were not included in the PAXI-XL study. And this is something that we are trying to collect and publish, PAXI-XL in fungal infections. So as an adjuvant to antifungal, topical antifungal treatment. The other thing is we are having very good results, and this is something that I'm really excited about. We're having very good results in recurrent infections. So if you have an infection that you think that it's all gone and everything's absolutely fantastic, especially in degenerated corneas, if you have like recurrent graft rejections and stuff, and you have a small corneal abscess, you treat it and it ends up with a small dot of opacity, and you think the organism has died completely. A year later, it comes with reinfection. These subcategory of patients you can only do as cross-linking, and everything will be fine.
Thank you very much. That's a great. I think we need to...
just have a question, Dr. Osama, if you don't mind.
Yeah,
Dr. Thanks for your excellent presentation. I totally agree with you with the recent resistance of organisms and challenges we have faced with treating these microbial infection. We are giving a lot of hope that cross-linking will be a better alternative. My question or your advice and comments earlier on when the cross-linking started to be popular to treat infectious keratitis, there were cases of perforations, and this is why many trials has been stopped. And I'm still, to be honest with you, some reluctant. I reserved the cross-linking. I haven't done any cross-linking for any infectious keratitis yet. But what is your advice to avoid such a complication?
I don't have any. I know exactly what you're saying, and I will be the devil's advocate. Actually, people, including myself, had doubts at first because we have seen corneal melting and infections post cross-linking for patients with keratoconus. So how would we develop the courage to give patients that are already infected cross-link a session of cross-linking? My answer is, if you do have a cornea which is eminent to perforation, which is eminent to melting, then definitely do not go ahead and do a cross-linking. But if you do have a corneal ulcer, a definite infective corneal ulcer, a dirty ulcer that there's no like a decimetocele or something, that's why the timing is very important, Murad. If you start off with your corneal cross-linking, it is extremely unlikely to have a corneal melt. But if you bombard the cornea and the eye and marinate the cornea with a lot of antimicrobials, and then you don't get any improvement, then you decide later on to do a cross-linking, then there is not a high possibility, but a higher possibility that you will get a corneal melting or a corneal perforation. But this is very well taken. This is a very good point of debate.
Thank you very much. Because of time, I think I need to move to Murad. The next speaker, Dr. Murad Vatani, is a consultant specialist is a corneal specialist at Khalifa Hospital. So he will be talking about bacterial keratitis. And the end, if we have a time, we're going to discuss more about back, I think.
I think, Wes, I will have to go. So thank you so much, guys, for including me in the program, and I have to run.
It's a pleasure. It's a pleasure. Thank you.
Okay.
Thank you, Dr. Osama, for the introduction. It's a pleasure to be among such a group to discuss about microbial keratitis. And I probably given the easiest and at the same time, the challenging, some cases can be challenging bacterial keratitis. So I'll be talking about an overview and clinical approach. First of all, I just wanted to remind the audience about the normal flora. And just be aware that there is normal bacteria is part of normal flora of our conjunctiva and eyelid. These are also the same causes of microbial keratitis or bacterial keratitis, which including staph and streptococcus, as well as sometimes fungi or yeast. So those organisms that most likely can cause bacterial keratitis are Staphylococcus aureus, which we saw earlier that it's part of the normal flora, as well as strep epidermis and strep pneumonia. Pseudomonas is also a very common one. The uncommon ones are Neisseria, Moraxilla, Mycobacterium, Nocardia. Those are uncommon causes of bacterial keratitis. I like this slide because I like to define which organism we are dealing with, especially with the gram stain. That's why it is very important to do a gram stain at the beginning when you see any infectious cases. So gram-positive bacteria like staph, strep will respond to different kind of antibiotics, and gram-negative, especially Pseudomonas rods and Enterobacter, will be a different medication responding to those organisms. So how we can modify our clinical approach to microbial keratitis? First of all, any microbial keratitis is supposed to be bacterial until proven otherwise. So you need to do patient assessment and then rely on investigations, which include corneal cultures. And then I will be talking about the medical and surgical management. I'll just point to the important questions or risk factors that you need to ask in your history taking. First is the course of the disease. If the course of the disease is rapid, you would be thinking more of a bacterial infection. If you think this patient has seen many physicians, taking multiple antibiotics, you would be thinking of co-infections or different organism like a Canthamoeba or fungi. Risk factors, aware of the ocular surface disease, if there is any risk factors. Also, it's very important to ask about corneal anesthetic abuse. So especially those who are working in the medical sector, nurses or allied health, or even physicians who could be using anesthetic post corneal abrasion. When you look at the clinical features, so when you're thinking of a bacterial infection, you need to document the size and the location of the infiltrate, like the top right picture. This is a large seborrheic infiltrate, typically seen in a bacterial infection. It's a single infiltrate, but you need to be aware of the other feature that suggests non-bacterial keratitis, like the lower two images when there is elevated edge, or if there is any feathery margin, satellite lesions, or if there is any discoloration. Also, you need to look at the hypobion as it signifies the infection and the risk of vision loss. So I like to differentiate the microbial keratitis or the bacterial keratitis into site-threatening and non-site-threatening. Site-threatening, you need to be more aggressive with the treatment. Those are the infiltrate, which is center or paracenter more than 2 millimeters, associated with hypobion, and if there is any history of contact lens. The peripheral small ulcers, I will be calling them non-site-threatening, and they will be responding very well with monotherapy. While the site threatening, you need to culture and use fortified antibiotics. Of course, you need to do the corneal smears, especially for gram stains. And if you're suspecting fungal, you do the other smears. Cultures for site threatening corneal infection, you need to do blood and chocolate as well as seborrhoid and thygoglycate. If you're worried about acanthamoeba, you do E. coli overlay. If the cultures is negative and the patient is not responding to treatment, you can consider other option, including biopsy. BCR is expensive, but it could be useful tool. You can do an anterior segment OCT, and I think this is a good point to see the thickness and to be aware if there is any impending perforation. If the view to the anterior segment is not clear, the lens and the iris, anterior segment might be a useful tool. Confocal microscopy is an excellent tool. We don't have it here. It is operator dependent. The sensitivity could be high, depends on the operator, especially when you are worried about acanthamoeba or any other features of fungal keratitis. Now, I want to point out the importance of which antibiotics to use. First of all, dividing the antibiotic to aminoglycoside like tobramycin and gentamicin. I personally use tobramycin. It's less toxic to the cornea, and I use it in a fortified way. Many people will do the same, but the tobramycin and the aminoglycosides cover the gram-negative organism. So that's why the gram stain is very important to decide which way you run your antibiotics. And then I'll talk about the cephalosporins and glycopeptide like vancomycin and cefazolin. These are more toward the gram positive. I will reserve vancomycin to MRSA cases and resistant cases. Cefazolin and cefuroxime are a good gram positive coverage. Fluoroquinolone, like ofloxacin, moxifloxacin, and gatifloxacin, is good, especially for monotherapy and when you are tapering the fortified antibiotics. And moxifloxacin, for example, is preservative-free. It can be used when you are worried about toxicity, and it's a good option for monotherapy. So, as I said earlier, non-site threatening, I would be happy to start moxifloxacin every 5 minutes for the first half an hour, then Q1 1 to 2 hours, depend on the severity and the response, and I will taper it until we see a recovery of the infection. For the site-threatening cases, I will go more aggressive with fortified antibiotics, tobramycin and cefazolin, and I will taper very slowly, but I need to be aware of the toxicity. Other medical consideration, you need to control intraocular pressure. You might use oral acetazolamide, or you might use topical. You need to control if there is any melt with doxycycline. If there is any scleral extension or impending perforation, consider systemic antibiotics. Of course, you need to use mydriatics to avoid membrane formation and occlusion of the pupil. This is a case of a patient who presented to me previous history of OSSN, medication, ocular surface disease. You can see the eyelids have blepharitis, definite ulcer with a hypopen, mainly hemorrhagic. Improves very well with the fortified antibiotics. Epithelium started to close, but then he presented with this epithelial toxicity because he had already had poor ocular surface, and the fortified antibiotics were toxic to the epithelium. Eventually, he improved very well with the tapering of the fortified antibiotics. Surgical option, I just wanted to show this glue. This is non-infectious cases, but this is the way I do the glue. Perpendicular, patient is lying flat. Use a 2 to 3 millimeter disc and the remaining part, if there is any gutter, you can do direct gluing in this area. Other surgical options aside from the glue, you can consider a small tectonic graft like in this area to cover the perforation, or you can go with the optical keratoplasty. When all the infection is settled down, you can consider using optical keratoplasty. As Dr. Muhammad Hasni said earlier, hot keratoplasty might cause recurrence of the infection or failure of the graft. I use it, but I prefer to wait until we get an optical keratoplasty. So in summary, bacterial keratitis is the most common type of microbial keratitis. Be aware of suspicious features and signs. Site-threatening infection need to be cultured, and fortified antibiotics should be used. Fortified antibiotic can be toxic, so be aware of that, and be aware if there is any co-infections if the patient is not responding. And if you can defer keratoplasty, unless there is any need for it, it will have a better outcome. Thank you, and sorry for taking extra time.
Thank you, Dr. Murad. Thank you. I will leave the discussion later. I think I will go straight to Dr. Sandeep Mitra, who is a consultant, corneal specialist at Zahra Hospital. Sandeep, can you share your slide, please? So Sandeep will talking about herpetic keratitis, do's and don't, which is a always tricky subject.
Yeah, can you see my screen now?
Yes.
Is it visible or?
Yeah.
Okay, is it visible now?
Yes.
Okay, all right. So my topic today is basically herpetic keratitis do's and don'ts. But let me just start by saying that herpetic keratitis is probably one of the most commonly misdiagnosed and wrongly treated keratitis. Basically, let's try to look at some of the cases we present. Here we have a 67-year-old UAE national MA presented with pain, redness, and drops in the eyesight for last 1 month. He was diagnosed as keratitis and treated with cocktail of antibiotics and steroids. And his vision was 6/60, ciliary congestion. There's a large geographical ulcer, KPs, with some cells and flare in the anterior chamber. Diagnosis and treatment with corneal sensations was reduced. That's very important in if you want to diagnose herpetic keratitis. Corneal scraping was done for gram stain and KOH mount. It's basically to rule out any form of keratitis. You have to do a gram stain and KOH mount. A presumptive diagnosis of herpes simplex keratitis was made. All the drugs were stopped. We switched to Zovirax 3% ointment 5 times a day and oral Valtrax 500 milligrams twice a day with lubricants. And patients slowly recovered over 2 weeks with vision of 6/12 with reduction of residual scarring. This is another case where a 25-year-old Filipino girl presented with dry eyes and very poor ocular surface, keratitis, treated with lubricants and antibiotic drops for 1 week with no improvement. Now, this sometimes gives you a clue when you are treating any form of keratitis and the ulcer is not responding. I think that's the time when you start thinking laterally and think of something else which you are missing. Again, here there was a reduction in corneal sensation. The ulcer looked a little bit like a geographical ulcer, and patient was put on Zovirax 3% and Valtrax, and again, the keratitis resolved. Sometimes, now this patient presented with severe photophobia, epithelial defect, a vascularized corneal opacity, and epithelial opacity with reduction of corneal sensation. He was again started with antiviral treatment, and again his vision improved. So we have seen various modalities of presentation. It can be a dendritic ulcer, it can be a geographical ulcer, or it can be a vascularized interstitial keratitis. So these are the varied ways how herpes can present. So what is herpes virus? It's basically a double-stranded DNA virus. It can be herpes simplex, type 1, 2, varicella zoster, CMV virus, and Epstein-Barr virus. Now, these are basically types of herpes virus which we get. Primarily, it stays dormant in the ganglion, which is the trigeminal ganglion, and it waits for any form of insult, which is like reduction in the immunity in the system, like triggering with fever, sunlight, any form of stress, and then it starts moving back from the ganglion back into the nerve and back into the cornea. So when this happens, there is a loss of corneal sensation. So this is very important point when you start diagnosing herpetic keratitis. The commonest form is epithelial keratitis. It can present just like blepharoconjunctivitis with no corneal involvement. That could be the earliest sign of herpes. It can present as rhinitis, trabeculitis, uveitis, optic neuritis. These are the other ways of presentation, but most common is a dendritic ulcer. And if you have rose Bengal, that actually picks up herpes very early. Otherwise, just a simple fluorescein stain will stain the tear film, and it shows a nice dendritic pattern. The exact classical presentation is a terminal bulb with borders and raised margin. And in the rose Bengal, it stains the degenerated epithelial cells, and you can get what is called as a positive and a negative staining pattern. Sometimes there is a resolving of the dendrite and presents as a ghost dendrite with superficial stromal opacification. Now, if you don't treat a epithelial ulcer properly, then it becomes a large geographical ulcer. This basically shows the herpes has started multiplying more vigorously. And of course, if you treat the herpetic ulcer, sometimes they become metaherpetic, where the virus is not there anymore, the loss of corneal sensation, and the ulcer doesn't heal because of poor epithelial growth. Now, this is the condition wherein you have to stop antivirals and go towards tarsorrhaphy, lubricants, and other managements of metaherpetic ulcer. Now, this is a different type of a presentation. This is called disciform keratitis. Now, this is one of the indications wherein you have to start steroids under the cover of antiviral. It is immune mediated. It can be focal, multifocal, or diffuse. Interstitial vascularization is present. There is a leakage of lipid in these cases, so you can see yellow margins in these cases. Sometimes there's a localized edema due to the virus antigen, and there are Desmond folds and KP. So these are the signs of typical disciform keratitis. This is the other presentation of herpetic keratitis. It's called keratouveitis, wherein you have a granulomatous uveitis with large mutton fat capes. There will be sectorial iris atrophy, endothelitis. Sometimes there is cataract and glaucoma. So this is one type of uveitis where the intraocular pressure actually shoots up, whereas the other uveitis you may find the IOP is low. So this is what is the other feature of herpetic keratouveitis with glaucoma. This is a patient where there is a severe form of necrotizing ulcer. It can be missed in some cases with rheumatoid or a Murine ulcer. It is a necrotizing keratitis, wherein you see a very severe melting of the cornea and stroma, and also the sclera leading to perforation. And in these cases, there is a very high incidence of glaucoma because of involvement of new vessels in the angles. Coming to the diagnosis of herpes is mainly clinical. However, there are techniques like you can do a PCR in some patients. You can do a fluorescent antibody test, a zinc smear test, or a serum antibody test, or you can even take aqueous tap and try and look for herpes virus. So these are the lab tests, which is not available readily in every hospital. So a clinical diagnosis is probably the most important. Now, coming to treatment, I think the most important thing is avoidance of steroids. So whenever you have an epithelial ulcer, which is herpetic in origin, try and avoid steroids because it might prolong the virus and it might actually change the pattern of the ulcer. Debridement is very important. Just by removing the virus load from the epithelial cells, topical use of acyclovir is probably the better way of treating than trifluoridine. You should treat them at least 2 to 3 weeks for the complete resolution of epithelial involvement. If there is a stromal involvement, you have to give steroids, and you can cover it with oral antiviral. That's the recommendation of the head study. Epithelial disease, head study says no benefit of adding oral antiviral to topical antiviral therapy. So in these cases, you can just continue with topical antiviral treatment. Also, the head study says that oral antiviral reduces the recurrence in all form of herpes simplex virus. So it's a very important that once you diagnose herpetic keratitis, you must start the patient off on oral antiviral treatment. So that's about it for me. Basically, I was supposed to present do's and don'ts. So I actually presented an overview of herpetic infection. I think the main don'ts in these cases are that you should avoid steroids when you diagnose herpetic keratitis. The other important mixture which we get is early acanthamoeba keratitis. Sometimes they mimic like herpetic keratitis, and there is a lot of overlap when you're treating a acanthamoeba patient, and these patients are sometimes treated as herpetic keratitis. So the most important point is that once you diagnose herpetic keratitis, you must try and do two things: one, staining, and the other is corneal sensation. Thank you.
Thank you very much, Dr. Sandeep. That's great. Yeah, definitely. I think it's underused, the corneal sensation testing. When you have the corneal ulcer, always really good to check corneal sensation. That will help you not to miss something like this.
Thank you.
So next talk is my talk. So basically, I'm going to talk about the acanthamoeba keratitis. I had no financial disclosure. Is it moving the screen? Acanthamoeba.
Yes.
Yeah, thank you. Sorry for that. Acanthamoeba, as you know, is a free living single cell organism. There's almost more than 24 species recognized and really affecting either the cornea or the brain. They have two cycles. It's a trophozoite, which is active phase, or the cyst, which is a double-walled cyst. Basically, it's the cyst. If there's any resistant high temperature, chlorine in the low level, that's becoming a cyst. But when it's want to nutrition and there's no any medication, it changed to a trophozoite, which is the active phase. It's motile and it starts destruction the cells. But any stress, lack of nutrition, is go to cyst. The problem with the cyst is resistant to many things. So everything try to hide in the cyst when it's active. Acanthamoeba is really present everywhere around us, from the water supply, the tap water, the tanks, beach, over our surface, vegetable, soil. So everywhere around us, we can get acanthamoeba. The epidemiology, it's the most common now related to contact lens as a risk factor related to people who had poor hygiene, soft contact lens more than rigid or ortho-K. Non-contact user is usually related to trauma, contamination soil, poor socioeconomic because of the water contamination. In the Middle East, there's one publication showed it used to be the trauma, the commonest cause, but now we move it now, the contact lens is the commonest cause, especially now people using a lot of even cosmetic contact lens. So when the patient coming to you, if the patient had within a few weeks the symptom, think about acanthamoeba, but it could be because of fungal, low virulent bacteria. Usually acanthamoeba associated with severe pain, but acute keratitis and more can also cause severe pain. If someone had the trauma, more likely fungal microsporidia, but it could be acanthamoeba also. Always think about acanthamoeba if any patient had wearing contact lens, especially if he's had the poor hygiene about contact lens. If the pain over proportion, the sign you see, and if the infection is slow, not responding to antibiotic, usually it's presented affected epithelium first. So usually this patient presented to punctate epitheliopathy, and also it's presented what Dr. Sandeep says, like dendritic lesion. So this could be the misdiagnosed as herpetic. It's the acanthamoeba tends to invade the nerve and eating the nerve. So that's why you can see the nerve inflamed, we call radial peritonitis, which is pathognomic. If you see it, that's most likely is acanthamoeba, and that's why this patient has severe pain. Later on, it's infiltrating deeper, so it causes stromal infiltrate and what you call ring infiltrate. When it's the other type, people had the injury related. Usually they have more deeper stromal infiltrate, usually like a gray-white superficial infiltrate, go deeper and advance it deep. The poor prognosis usually associated with someone delayed treatment and steroid use. This is the two factors which can make the cantilever penetrate deeper and will have poor prognosis. Ring infiltrate usually it can be presented in a cantilever, but it could be also presented by fungal, viral. But one thing we shouldn't remember is anesthetic abuse. People had severe pain, they could use anesthetic, and that can give you ring infiltrate and misdiagnosis. There's a reported outbreak before a cantilever solution. One of the MO, which is contact lens solution, was contaminated with the cantilever, and they have to withdraw from the market. The misdiagnosis of herpetic, it's almost 50% of the cases initially treated as herpetic and misdiagnosis. But remember, any patient who poor responded to antivirus, they have more pain and they don't have previous recurrent problem. Think about this. And also if someone wearing contact lens. But if you look carefully, especially if you use rose Bengal, you could see the branching. There's a little bubble at the end of it. That's a typical of herpetic one. The other misdiagnosis, which is I think is growing more now, what you call microsporidium keratitis. Usually like multiple superficial punctate keratitis, and they have like raised edge, but that's later can go to stromal keratitis. Diagnosis, as with Dr. Murad, it's always any ulcer you need to take smears, but if it's suspected with the cantilever, ask it for cauliflower, but the gram gimsa bass also you can see the cantilever in majority of cases. Culture, a new nutrient agar with E. coli overlay, that's the standard culture, but it can grow even in blood agar. Biopsy is another modality to diagnose, and the confocal really is very useful, but is we don't have it here, but really very useful, especially for cantilever and fungal, especially when it's deep, so you cannot scrape it, and they have very, very sensitivity. BCR is another modality which is very helpful to diagnose it. Remember that if you do it early, you remove the epithelium as it's therapeutic, but also that will give you high chances to get the cantilever diagnosis. Later, consider biopsy. Don't forget that if the patient wear contact lens, just also send the contact lens for cultures. About the disease, it's really early stages. You remove the epithelium that help debulking and promote the healing. But you need to remember this is slow infection. You need to consider anti-amoebic 3 to 4 months. Once you go deeper, it's more difficult to eradicate, and you're talking about 6 months to a year. So it's very important to explain to the patient when you treat it. Basically, their treatment consists of 2 ways. Some medication work in trophozoite active phase, like Proline, Muconazole, Itraconazole, Neomycin, but always you need to consider cysticide, which kill the cyst, because as we say that trophozoite, when it's stressed with any medication, change to cyst and stay long. So you have to use also cysticide medication like BHMB, chlorhexidine, bovidine, iodine, use it, but it's toxic to the surface. Usually you have to combine both of them, either chlorhexidine, BHMB with Proline and hexamidine, and usually hourly for the first 3 days, then slowly reduce them down over the time. But remember that you need to use the cysticide medication at least 3 months. You could consider systemic itraconazole or vulcanazole in severe cases, but if it doesn't respond, then you may need to consider corneal graft. People try to do deep lamellar corneal graft as possible, not penetrating, but sometimes it's challenging if it's deeper penetration. Steroid, it's if some people start steroid, usually they have poor visual outcome. It's still controversial. If you're using steroid, you need to use cantilever first, and the patient improving, then you may consider steroid to reduce the scar, but you need to continue also a cantilever medication 4 weeks after the steroids stop it. The indication for steroid when it's very severe anterior segment inflammation, iridocyclitis, or scleritis. The other modality, like Dr. Muhammad mentioned earlier, about the back cross-linking. Back cross-linking, which is using ultraviolet light to kill. It's a very effective way in bacteria, but it's slightly lesser in acanthamoeba and fungal, but it's really still good modality when the other medication fail. And usually most people are using high fluence, so 7.2 millijoule, and some people they even repeat after a few days more. There's different study, although small number of cases reported effective of back for different corneal infection. One of them is acanthamoeba. conclusion, Candida keratitis uncommon, but potentially devastated, especially in a healthy person wearing contact lens, and it can be presented with both eyes infection, so it can be very serious, devastated to the patient life. You should have high index of suspicion. Anyone had contact lens and they have more pain than what you see. Diagnosis could be delayed because if you diagnose as herpetic, early treatment have better outcomes. So it's very important to look for early diagnosis and you start that treatment immediately. Medical treatment is very useful, but long. And the problem we had it here is really there's shortage in the Candida medication. So it's not easy to get access. And sometimes we have to import it from outside at regular basis. Corneal graft may be needed, but better to, even if you need corneal graft, better to control the infection, reduce the inflammation, to have better success of the corneal graft. Contact lens education really here is very crucial because most of our Candida is really related from contact lens, and really people should be educated to prevent it better than treatment. And thank you very much. So the next, any question from our panelists?
Thank you, Dr. Osama. I think, do you want to keep the questions at the end?
Yeah, we'll go to Sharif Amara. And so next speaker is our colleagues, Dr. Sharif Amara. He's a consultant in eye consultant clinic. Basically, we're going to talk about fungal keratitis. Then we'll leave a bit of time for discussion. Sharif, it's all yours.
Dr. Osama, while waiting for Dr. Amara to load, I think it was an excellent presentation about the Candida. I just wanted to highlight the point you mentioned, the pseudodendrite and dendrite. I receive many patients who have been diagnosed as herpetic keratitis, treated with steroid for a long time without improving until they develop a ring ulcer, which is a late stage of acanthamoeba. So early recognition is very important. I think Dr. Amara is ready then.
Yeah, now start the fungal keratitis slide, the first one.
Okay, so my talk today will be fungal keratitis. Fungal keratitis is a fungal infection. Keratomucosis is a fungal infection of the eye. Usually, it's causing 17 to 48% in corneal ulcer in tropical and subtropical regions. We have different species for fungal keratitis. We have the Aspergillus, Candida, and mucormycosis. We have the filamentous or hyphae and the yeast, which is in shape. The Aspergillus is the most common organism worldwide. It depends on the region. In northern United States and Canada, Aspergillus is more common, and Candida, and southern in USA, the Fusarium is more. In India, Aspergillus is more common, from 27 to 6 of the keratitis. Different risk factors of fungal keratitis. The most common thing is trauma and contact lens use. Definitely topical medication like long-term use of steroid and broad-spectrum antibiotic after corneal surgery, after PKP, after LASIK, and also chronic keratitis, one of the most major risk factors for fungal keratitis. The most important sign for the fungal keratitis is a corneal infiltrate, which is unique in shape. Usually it's feathery margin, elevated edge, and rough texture, satellite lesion, and sometimes endothelial plaque. And hypopyon also for the fungal keratitis is a little bit unique in shape. It's non-sterile and thick and immobile. We have sometimes in some patients we have immune rings, like also the one we found in acanthamoeba keratitis. The most important issue in fungal keratitis is rapid and early diagnosis can reach to corneal melting and perforation. So this is the important issue in fungal keratitis, and we have a lot of diagnostic issues. We have a corneal smear, corneal scraping. The corneal scraping, we can use the spatula, we can use surgical plate, we can take biopsy. We are using gram stain. We can use also James gram and James stain of corneal scraping has sensitivity about 50% of establishing the diagnosis. Calcoflower white is also one of the diagnostic tools for fungal. It is very good diagnostic tool. It's rapid. It takes few minutes for the to the ear and to the under microscope to use it. And the specification of protein and potassium is more than 83. Definitely the culture is important, and it takes 72 hours, and for the 83% of the culture, and within 1 week 97% we have initial growth. A waiting period of 2 weeks is usually necessary to confirm the growth. We have recent and diagnostic tools for diagnosing of bacterial infection, especially the fungal, like confocal microscopy, anterior segment OCT, and PCR. PCR is a very good issue. We can see here the results of different corneal infection diagnosed with PCR. Are very rapid, 2 to 8 hours. And one of the advantages also of PCR is that we need a small amount of tissue to get the diagnosis. And comparing with conventional diagnostic tool like other culture, it takes at least 72 hours to get the diagnosis. And we can see here different analysis of different papers and comparing the PCR versus other diagnostic methods for fungal. And we can see here that the PCR has a little bit superior advantage over the other diagnostic tool in regarding the sensitivity and specificity. The other one is the in vivo confocal microscopy. With the confocal microscopy, we are doing optical sectioning of the cornea, so we can see the corneal issue in more all the confocal microscopy sensitivity for fungal keratitis are 80 to 94% of the cases. In the most important issue of vivo focal microscopy that we have
while waiting for his to rejoin again. So Murad, what's can you hear me, Murad? Murad, can you hear me? Or Sandeep?
Yes, Osama.
Yeah, sorry, it's because there's I think it's we lost Sharif. Sharif is while he's joining us, I think we can discuss about when you had the patient coming with corneal ulcer, which one you don't do scrape for them?
I think I mentioned in my presentation, I divide them in site-threatening, a non-site-threatening presentation. If I'm worried about the site-threatening condition, definitely culture. If there is a peripheral ulcer, mild, I probably start them and keep a close eye on them. If I need to stop the antibiotic culture or start on fortified antibiotics. Some of the problem, I received many patients who started on antibiotics treated by my colleagues who don't have access to cultures, and they start empirically on antibiotics, and they come with a failure of the treatment, and they use monotherapy. So there was always a question, is this still bacteria? If the patient is not responding, am I treating with another thing? If there is any resistance? I would stop the antibiotics for 24 hours, or even with the antibiotics, I might culture, especially if there is any fungal, and start them on the maximum fortified drops, even if I'm worried about ocular surface disease. This we can manage later on once we cure the infection. I think while waiting for Dr. Amara, we probably need to discuss, because I think he covered most of the fungal keratitis. The only remaining part probably is the management. Do you want to discuss the management of fungal keratitis?
You can go ahead with that.
I think for the audience.
Yeah, go ahead until he joins us. Yeah.
All right. Okay. I think for fungal keratitis, as you mentioned with acanthamoeba, it is a challenging management. Those treatment could be difficult. It would take a longer time with both acanthamoeba. Here is, I think Dr. Amara is back.
Sharif, we had 2 minutes, okay? If you jump straight to the treatment. Yeah, the availability of the antifungal it's not easy. Yeah, go ahead. Can you hear me, Sharif? Sharif, can you hear us? So the problem with antifungal, most of them is fungostatic. So you need to have very longer duration of treatment, and you need to prepare. Then they're really expensive, some of them.
Yes, and unfortunately, those. Okay.
Sharif, we had 1 minute. So if you go last slide, maybe for conclusion.
Okay, we have a lot of antiviral. We have a lot of antiviral tint. Can you hear me, Usama?
Yeah, I can hear you. If you go to conclusion, maybe.
Okay, we have topical natamycin, and we have voriconazole, and we have amphotericin B. Amphotericin B used intrastromal and intracameral, and fluconazole also we are using it topical and also for systemic use, and we have used for a long time. Povidone iodine has a role also in fungal keratitis. The corticosteroid, we have to use it with cautious because we have to be very sure that we already controlled the infection. So there is no specific treatment, or there is no good broad spectrum antifungal medications that is effective in all cases of keratitis. Role in treating fungal keratitis, we have a debate for the accelerated one. The problem that sometimes fungal is deep, so cross-linking is treating still an option. The BKB and amniotic membrane, steroid after surgery is also debates, and we have to use antifungal treatment after the DALC or after the PKB. I have 2 cases here just to join. I have one patient with fungal keratitis after cataract extraction. She has endothelial. We have endothelial plaque. We can see here in OCT, and after amphotericin B, we can see the thing of the endothelial plaque. The other cases of fungal after long-term use of topical steroid, it's not responding to topical treatment. So I tried the cross-linking, and we can see here improvement after cross-linking treatment. Thank you so much.
Thank you very much. Thank you to our speakers. And thank you for our audience. Hopefully that course will help everyone to manage corneal infection. Thank you. And because we're running out of time now, it's a pleasure, and look forward to meet again.